Welcome to our channel. The topic for today's discussion is thoracotomy, that is open thoracotomy. It will be a step-by-step guide for the beginners and surgery trainee, and we have designed this video tutorial in keeping in mind the interest of training that the indication of open thoracotomy are less and less in the present era, and friends, open thoracotomy or thoracotomy for that matter is a life-saving procedure, and every surgeon or surgery trainee should have this technique in their armamentarium because when it may be required at odd hours and it can be a difference between life and death for a patient of chest trauma. So this will be a complete guide for all the trainees and beginners. So stay tuned till the end. We have demonstrated all the essential steps. Initially, we have a short theory part as we do in all our videos, followed by live demonstration of the surgery. So happy learning, friends. Stay tuned till the end. So the indication of thoracotomy can be the surgical treatment of distal aortic, cardiac, esophageal, and pulmonary diseases. The distal thoracic aortic disease can be dissection, rupture, or aneurysmal disease. The cardiac disease may be congenital cardiac defects, valvular diseases, specific location of coronary artery disease, pericardial diseases, and certain tumors of the heart and pericardium. The pulmonary malignancy, primary or metastasis, pleural malignancy, and empyema are other indications for the thoracotomy. The indication like the cardiac, the thoracic, these are mainly under the domain of CT surgeon, and we will be called upon to do the thoracotomy for a patient of maybe the malignancy of the esophagus, or it can be the trauma indication. So we will be focusing our discussion on those parts. As I said, in adults, the esophageal cancer is one of the most common indication, and tracheostomy fistula in infants. The right side thoracotomy is best for the mid-esophageal diseases, and left side thoracotomy allows better access to the distal esophagus. A transsidal approach may be used as per the case-to-case basis, and the emergency indication for thoracotomy will be massive hemothorax, cardiac resuscitation, and decortication of the entire lung segment, which we will discuss in subsequent part of the video in detail. The indication in a trauma patient typically include shock and arrest at presentation, or you are suspecting a specific diagnosis like blunt aortic injury, or there is an ongoing thoracic hemorrhage. Trainees often confuse this indication. So the indication of ongoing thoracic hemorrhage means that there is a more than 1500 ml of blood output after placing a ICT, that you placed a ICT and there is more than 1.5 liter blood in the chest tube, or patient is having persistent bleed of more than 250 ml per hour for consecutive 3 hours, then it becomes the indication of emergency thoracotomy. So generally, you will be called upon to do the thoracotomy, emergency thoracotomy, after traumatic injury of the chest in 3 scenarios only. That means patient is in shock or cardiac arrest, and the cause is suspected intrathoracic lesion which can be corrected after thoracotomy, or you have a specific diagnosis of penetrating cardiac or blunt aortic injury, and or there is a evidence of ongoing thoracic hemorrhage, as I have discussed just in the previous part of video. So friends, these are the main indication of open thoracotomy, and I urge my viewers that these video tutorial are meant for education information only, and are not a substitute of proper surgical rigorous training, and no trainee should attempt any procedure without the guidance and supervision of a qualified surgeon. The technique and position of the patient. So for right thoracotomy, patient will be placed in a left lateral position. So patient is placed with ipsilateral side elevated. That means if we are planning right thoracotomy as in this case, so patient will be left lateral position with the right side up, and he will be tilted further 30 to 45 degree. That is, the angle with the horizontal will be 30 to 45 degree, and so this is called a skyfall position. The arm is abducted above the head, resting on the arm rest or of the pillow, and we elevate the bridge of the table or place a sandbag beneath the rib cage so that the rib cage on the right side or the above upper side opens up, and so the bridge of the mm, table is broken like in a jackknife or in the kidney position. And usually the fourth and fifth the space between fourth and fifth rib is usually the space we enter, but it can be modified depending on the position. So the incision is lower, so we can go below the fifth, or if the incision very high, we can go above the fourth. But the fourth and fifth along the superior border of the fifth rib is the usually safest entry of the chest, and the intercostal musculature are divided along superior border of the rib to prevent damage to the neurovascular bundle that runs along the inferior border of the rib, that all of you know already. So basically, there are two types of thoracotomy described in literature, and one is posterolateral, another is anterolateral. So the posterolateral thoracotomy, it is the gold standard, and that's what we are demonstrating in this video. It provides access to all the thoracic viscera, mainly used for pulmonary section, pneumonectomy or lobectomy, chest wall section, or esophageal surgery. Incision is made with patient in lateral decubitus position, which we have already discussed, and it starts between the scapula and mid-spinal line, and extend laterally to anterior line. So, friends, this is the most common and the patient-friendly incision, that posterolateral thoracotomy, and the postoperative morbidity is less because it's a muscle sparing and no major muscles are cut, and patient has a rapid or better recovery as compared to the anterolateral thoracotomy. So another approach is anterolateral incision or anterolateral thoracotomy, and it may be used for cardiac, pulmonary, or esophageal pathology. Incision runs from the lateral border of sternum to mid-axial line at fourth or fifth intercostal space, and it divides to the pectoral major and serratus anterior muscle. So, friends, as I said, it may fall into the domain of CTVS surgeons, but as a general surgeon or GI surgeon, you will really need this incision because they are highly painful, and they are more cumbersome also. So, the technique or the gold standard is posterolateral thoracotomy that we will demonstrate in this video. So, let's start our practical demonstration with the famous quote by William Osler, that he who study medicine without books sails an uncharted sea, but he who study medicine without patient does not go to a sea at all. So let's uh, have our theoretical background solid and our practical background solid, and we should always sail in a chartered sea. So coming to the index case, uh, this was a lady, 56-year-old female, a case of mid-thoracic squamous cell carcinoma esophagus. She had already received nutrient chemotherapy with good response, and now patient was planned for McKeown three-field open esophagectomy. Friends, the laparoscopic esophagectomy is the, gold standard or should be the preferred approach in the present era. But if there are some hurdles, or if there are some constraints, or if there is a complication during lap thoracoscopic esophagectomy, then you may require to convert, and then it becomes a life-saving procedure, that is open thoracotomy. So patient is under general anesthesia with double lung ventilation, DLT tube in situ, and that will help us to basically enter the chest safely and work more efficiently as the epilateral lung is collapsed. Patient is left lateral position. After placing the double lumen tube, patient is changed to left lateral position, and we place a sandbag below the rib cage so that the upper rib cage opens up, or the table bar may be raised as in a jackknife position, or like a kidney bridge, and patient is then tilted towards a semi-prone position, that is falling forward, or sky falling position with the angle of 35 to 45 degree depending on the convenience of the surgeon. The right leg is flexed at the knee with pillow in between two legs, right arm supported in the armrest or over the pillow. Friends, for thoracoscopic or laparoscopic assisted esophagectomy. Now the same position is used that we have described just now, and we have moved from the prone position to the this semi-prone position, or that is falling forward position, and in case conversion required, so without changing position, we can do the thoracotomy in the same position. So this is the position we use for open thoracotomy or for the laparoscopic thoracotomy, the thoracoscopic surgery of the esophagus. So patient is under anesthesia with a double lumen tube in a semi-prone position, and we have given this incision. So wish you a safe thoracotomy once and always. Uh, if you uh, if you liked our video, please share your love in the likes, and do subscribe to our channel and share the content with your friends. Happy learning, friends. Thank you very much.